faces here, all the big names here, and then me. Uh,
This is your
Jeff,
interview person.
is
Just
it?
kidding.
Hey, is that you there? Are you actually in the room with your? There he is. How are things going down at NC State?
Good, good. Um, I'm at home, not working.
Not working.
Because I gotta take my kid to the little bit kind of trip over the over the weekend. But we have the in the hospital they have the case. I think that's the Lyme nephritis, and they are doing a TPE.
Is it Jiwang today?
Yeah,
Looks like Cedric, do you have a case going in the background there too? Looks like your Phoenix is on.
Yeah, the Phoenix is setting up right now. We've got a dog that we've been dialyzing for a few weeks now. It's treatment number 12 today. It's a dog with suspect pyelonephritis that we dialyzed for a couple of weeks, I think. And it started to recover. The creatinine was around 4 for like a week without dialysis, and then she relapsed. And so we're like on the second round of dialysis right now. She like went back up to 9, and we're working on that right now.
And do you think her infection is kind of become resistant to whatever was treating for the pyelonephritis, or is there an ongoing injury, or what's any idea?
Well, we didn't find any other explanation. Our urine culture keeps being negative, but our CRP that initially improved with antibiotics and we saw some recovery went back up quite a bit as well. She's got persistent neutrophilia with bands, so there's definitely some systemic inflammation. We sent out some blood culture a few days ago. And we exchanged the catheter at the beginning of the week too. Not that I suspected the catheter was infected, but it was not working anymore. So we had to replace it anyway. But I figured that if there was like any catheter infection, that would be a good move to change it. Might improve the situation as well. So that's where we are right now. The problem is the dog was already on quinolone and cefpodoxime, and we didn't really have anything to prove persistent infection or any susceptibility testing to work with. So
Was there
let's see.
I
And no
had
pancreatitis.
okay. I had
Yeah.
a resistant pyelonephritis, or a pyelonephritis that didn't show any of that initial recovery of function. So she remained dialysis dependent. And we talked about going in, we re-ultrasounded her a couple of times, and she still had a little bit of pyeloctasia. And we talked about going in for a pyelocentesis because her urine sample was negative. Is that something that you're doing very much of?
Not quite frequently, no, but that's definitely the kind of case I would consider it, except that she doesn't have that much pyeloctasia actually. The one thing also that I did not mention is like when she was starting to recover, and so we the last dialysis treatment was on a Monday. On the Wednesday, her creatinine was 4.6, and she was giving some signs of recovery. The CRP was going down. Looks like she was responding. We decided to hold on the dialysis treatment, and she actually went down to 4.1 on Friday, and we sent her back home. And when she came back on the Monday, let's say that her dad didn't do a great job of a weekend. He didn't give the fluids. He didn't give the E-tube feedings, and she came back pretty dry. So I don't know how much of that has been responsible for the relapse. It probably contributed to, but then that should have improved right away when we started her back on dialysis and gave her some fluids. And her kidney function is not great right now. I think her creatinine on Monday was around 9, 6.6 on Wednesday. So yeah, and
Cedric,
the slope.
have you followed the cystatin Bs on that dog from
Yes. Oh yeah, I
initially
forgot.
to recovery?
I forgot.
Then
So
back
the
up?
cystatin B had gone down to like the 140 something, I think, and went back up to 3,500. So same thing. I mean, there's definitely a sign of that there's active kidney injury that is getting worse. There's systemic inflammation that has been persistent and now is actually getting worse. So that's what we're trying to figure out right now. So the working hypothesis that is that the pilot did not clear or became resistant to the antibiotic, or that we may have some other source of systemic inflammation / infection that we have not identified yet.
One other comment I was going to make, that Jethro sort of brought up, if you needed to do a nephropilocentesis and the animal doesn't have a lot of pelvic dilation, years and years and years ago, we did a whole bunch of studies. Actually, Jerry Ling and I did them to kind of document how lower urinary tract infections ascend. And you can just put a transient belly band around the dog and obstruct the ureters for 5 to 10 minutes, and then the pelvis will dilate enough that you could get the needle in very, very easily. We did it under fluoro at the time we were doing that, and now with ultrasound, it would be infinitely easier to do it. But we just would put them on the table and put just a soft belly band around the lower abdomen, obstruct the ureters, and the pelvis will dilate enough that you can get the needle in.
And that wasn't, you weren't like cranking it down. It was just a gentle pressure on there, or how much pressure do you think you had to apply?
Enough to kind of dent the abdomen a little bit, but it doesn't cause any harm or any pain. I mean, we were doing it under fluoro, so most of those animals were sedated or anesthetized. But I think you could do it. You could do it in conscience. Well, I don't know. You could do it in an animal that you would ordinarily do a nephropilocentesis on, so whatever degree of sedation or anesthesia you use to do that would be fine, where you don't have them moving. But that might be something to consider, that you've got an upper tract infection that just doesn't show up in the bladder. Sherry Ross and we demonstrated that in some dogs that we got entirely different bugs out of the bladder than the bugs that we got out of the pelvis. You probably remember those dogs that we did.
Do you remember if there was any crossover in terms of resistance patterns or susceptibility patterns, maybe between the different bugs in the two different places? Or is that going too far back? Because I mean, we're treating for what we grow out of the urine. First off, many of these times, are we getting lucky and there's susceptibility to those different organisms up higher?
Well, I'm not sure that we looked at that, or I don't remember. We probably submitted those urines for culture and sensitivity. We at least did it for culture because it was part of a research project. But I wouldn't rule out that there are differences in sensitivities if you get different bugs, or even if you got the same bug out of the urine in the pelvis, out of the bladder urine in the pelvis. I don't think we know that yet.
How often do you think we see this different culture results, different bugs in the paracentesis and the cystosynthesis?
Well, I've been trying for 5 or 6 years to get that study started, and nobody wants to do it because nobody wants to do the nephropilocentesis. And again, when we first started to recognize ureteral stones, that's the way we made the diagnosis. I mean, we would put a needle in the renal pelvis and inject contrast, and you could do that. We had clinicians at our San Diego program, internists they'd sit a cat in their lap, not even sedated, or maybe a little bit sedated, just put the cat in their lap, stick the needle in and hold it there, do the injections. It's something that's easy to do. We did it for a decade. It really doesn't, if you're good at it, it doesn't cause any damage or harm, but I can't get anybody interested in doing it.
Mm-hmm.
We had the protocol all written up and IACUC approval for it, but nobody wanted to do it.
The few things I still remember from my study from the ACVNU exam is that
Congratulations, by the way.
Oh, thank you. In the cats with the ureteral obstruction, I think I remember right that they saying that they oftentimes they have same bugs, so they most of the times on cats, you know, the cystocentesis results is gonna be same from that or maybe they are saying the more positive when the cysto results is negative, the positive negative, that's usually the negative, and that the nephropyrosynthesis results as well. Or they pretty much kind of get the impression that it's not necessary to do the pyrosynthesis in the cats with urethral obstruction, but I assume that's a different in the dogs with a different disease condition.
Well, I think
I suspect nobody's done that study. I mean, the reason that we wanted to do the study was to validate the biomarkers, particularly to see if these active injury biomarkers would predict pyelonephritis, or that if you've got a urinary tract infection, could you assume that the kidneys were infected if you had a positive active biomarkers? And so we wanted to do two things: measure the biomarker as it's coming directly out of the kidney, and also to identify whether there in fact were bacteria there or not bacteria, because that would certainly, I mean, the diagnosis of pyelonephritis is difficult enough, and if you had something like a biomarker that would tell you with this urinary tract infection, you probably have upper tract involvement, that would be a big advantage. And also one of my personal agendas was to see if these asymptomatic bacteriuria patients, whether in fact some of those patients ought to be treated because they have upper tract involvement.
Right.
But that, I don't think those studies have been done. I mean, we started doing it, but it wasn't, the study never got done.
And I do remember the study you're mentioning in cats. However, it's one single study, and I remember like years back, it must have been at ACVNU, another team presented an abstract, and that was kind of interesting because they had some cases where the pyrosynthesis was positive while the urine culture from the bladder was negative. And that was actually the conclusion of their abstract, is that if the cysto was positive, they had the same bacteria on the pyrosynthesis sample. And in some select cases with negative bladder culture, they had positive on the kidney, which kind of makes sense in some of these cats, like especially on the obstructed side. You can imagine that you're not getting the bacteria to go down to the bladder because the urine is not going down to the bladder. I don't think, I mean, I've looked around for that study if it had been published since then, but I haven't found it. So it remained an abstract, unfortunately.
Yeah, and that's what Sherry found in at least a few dogs, is that sometimes you would get culture positivity out of the renal pelvis, but you wouldn't get it, that you wouldn't culture anything out of the bladder. And unless you did a bladder cultured a biopsy of the bladder. So there's a good project for somebody. That's something that really needs to be defined, I think. The study that Jerry Ling did, oh gosh, I don't know, that must have been in the 80s maybe. So he would take and infect the bladder, and this was in experimental dogs. He'd infect the bladder and then do the nephropylocentesis and identify that the infection in the kidney was arrived from the bladder infection. And then he followed up with that, and then he'd infect one kidney and found that the other kidney became infected as the bacteria descended from the kidney to the bladder and then ascended up the other kidney. So there's a lot of communication between those various parts of the urinary tract, but a lot of that information has just stayed stagnant, I think. But it's a good area for investigation.
Florian's put something in the comments there. Florian, are you able to unmute and tell us about the study that you were referring to?
Yeah, I can, for sure. Hi everyone. I've done a study a few years ago about the outcome of subs in cats with Montreal's cats. And I remember having like few cats where we had like negative bladder culture from RDDM, and then once they were at the hospital, we were placing the subs, and we were having like some urine from the pelvis of these cats, and they were positive. So it did happen a lot.
Mhm. Yeah, it seems consistent. Then the two different populations make sense, especially in the obstructive disease. Like Cedric pointed out there, there's no flow of those bugs getting down to the bladder to culture. Cedric, did you? I mean, with this dog, are you changing your antimicrobial coverage in face of the worsening, or going with the inflammation of the
Yes.
injury as the cause? And
I did change, not so much because of a lack of renal function recovery, but more so because of a persistent band neutrophilia, the fact that the CRP is increasing again and that the cystatin B is increasing again. So I decided to change my antibiotic for something I'm not ready to confess in front of that audience without a culture, without a supporting susceptibility testing.
I was curious. Fair enough.
Well, I mean that's a problem, you know, because that dog initially from the first hospital, I think was hospitalized on Unicin and enrofloxacin, and was not responding very well. Came to the vet specialty hospital where they changed the antibiotic, and they chose to go for cefpodoxim and pradofloxacin. The only culture we have is actually an E. coli that was supposed to be sensitive to everything. So then how do you make sense of the fact that that alleged pyelonephritis is not responding to all of these antibiotics? I mean, it should have. So either the AKI is not secondary to pyelo and it's just like a misdiagnosis from the start, or something happened. And then where do you go from there when you already have cefpodoxim and a last generation quinolone? I mean, you don't have that many options, right? So it's a good thing my pharmacist was not around, because
Yeah, we run into the same. We've got some major hoops to jump through on the stewardship standpoint when we reach for something like a meropenem or something along those lines. And we've only done that a handful of times. The most recently it was for a respiratory case that actually did grow. We did get a sample and did grow something that was pretty multi-drug resistant.
I swear I did not reach for amikacin.
Do you just, there's a number of folks on here. I'd be curious, would you just take us real quick through your technique for replacing your catheter? And did you try and target a different endpoint for the tip of your catheter? Were you thinking that there was maybe thrombosis around it, or were you thinking it was intraluminal clotting?
So no, so the catheter dysfunction was pretty straightforward, because like we had a huge kink right at the insertion point. The catheter was actually a polyurethane catheter. I think it was a Myla 1216 or something like that. And we made it work for about 3 weeks, so I'm pretty proud of that. When we looked at the x-rays that were done after initial placement, the tip was not quite all the way into the atrium, was in the atrium, but still a little, the side holes were in the cava. But we got pretty good flows out of the catheter if it was not for the kink. So I actually chose to replace it by 11.520 to go a little bit further, and a Medcomp silicone catheter, which hopefully will be a little more durable. So the way I do it is usually so under like pretty heavy sedation. I'm draping the dog just as for initial catheter placement. Usually we scrub the catheter and somebody's just like holding it up so we can drape around properly. Cut the sutures, and we pull out the catheter a few centimeters, and you know how much you've got in, right? You know you've got your 16 in, so probably like pull it out like 3-4 centimeters. And then I clamp the catheter and I cut, because I don't want to be feeding my wire through the initial bloodlines, because those are likely to be contaminated after 3 weeks. So I'm actually using a part of the catheter that's in the dog. So I'm pulling it out, clamping, and then I'm using a guide wire to feed down the venous side. Once my wire is in place, I'm pulling out the old catheter and just sliding the new one over the wire, which takes like 10 to 15 minutes tops, if you're lucky. The good thing is you already had like a 12 French in place and you're replacing by a similar size, or even in that case, a little bit smaller. So you don't need to use a dilator. So it's pretty straightforward. I mean, you already got a line in. So all you got to do is to get a wire down as sterilely as possible, pull the old catheter out, and feed the new catheter over the wire. The catheter actually had some intraluminal clots when we looked at it, but the catheter function, I mean, you could tell that if you were straightening the kink during the treatment, you get like really good flows with not a lot of negative pressure. And as soon as you would let go, I mean, it was like going again. And as it's pretty typical in those situations too, like one lumen was more affected than the other one. Because when you think about it in those double Ds, when they kink, like you always have one lumen that is more affected. So we actually had to run that dog reverse for a few treatments before we replaced the catheter. Because we would get better flows out of the venous than the arterial.
I like how there are a number of, you can see around the room with folks with cameras on. When you said it was polyurethane catheter, everybody started shaking their head going, yeah, that's about right.
Yeah.
I'm
Classic.
surprised you got 3 weeks. I thought maybe you'd get 3 treatments.
I thought too, but
I know
wait a
every once in a
minute.
while, I'm pleasantly surprised when, I don't know if I've had one last 3 weeks, but I'm pleasantly surprised
Well,
when I get a week or two.
A few years back, we dialyzed the cat for 1 month on a 5 French, so that
Wow.
was not fun.
I think and I don't know, maybe it's come up in the academy. I think this is a bit of a mixed audience here, but I think your point around taking out the external part of the catheter and cutting that away so that you're not feeding a wire, because I think a lot of folks that might not have kind of thought through that might just feed through, one of the ports that's already there and then remove the whole catheter over the wire. So really, super important part there to get rid of the contaminated / exposed parts before introducing the new wire.
I mean, I guess if you've got a bloodstream infection and if your catheter is infected, you're still gonna you're not gonna resolve just by doing this.
Yeah.
It's just like, I think if you don't suspect, if you just change it for flow problems, you're gonna use a cleaner part of the catheter to feed your wire. That's the whole point.
Honestly, I think that's a great tip for any kind of long line. I mean, I think about how many PICC lines I replace, and I don't do that technique, but I probably should, because I spend a fair amount of time trying to scrub the outside of the catheter and the insertion site, and then having somebody that's not quite sterile try to like walk the catheter off my wire.
Yeah.
And it's never perfect. It's as good as you can make it in that situation, but I think that's a great idea of just backing it out a little bit. Cut your wire, make sure you're holding on to something quite well, and then feeding it into
Well,
a part that you know is clean.
the only tricky part of that is, depending on the catheter you're using, it might be difficult to identify which one is the distal lumen, right?
Sure.
Because I remember at some point we had some catheters with like 2 distinct lumens. So like the round one was the distal, and the moon one was kind of like the proximal or something. Now with these double Ds, I mean, I love the double D architecture because that's where you get the most lumen per like catheter size. But the problem is you cut your catheter and you've got those 2 lumens and you need to pick one. And so you start to feed your wire down. And once you hit a roadblock, you're just like, am I going out of a side port? Should I try to the other one? So, and it's just like, I don't know if you've seen that with the old USB keys. We always have 3 sides. Yeah, you try them one way, it doesn't work. Try them the other way, and you realize that actually the first way was the right one. And that's usually what happens. Like you feed down one lumen, it's like, oh, I'm hitting a roadblock. I'm gonna be the arterial. I'm gonna go on the other side, and the other side doesn't work either. And you go back to the first one, and then it goes down. So it's really a matter of like feeling with your fingertips and your wire if you're like in the right spot. And that happened to me in a bigger dog, I think a big Labrador that we had a few months back, where the wire went down smoothly. And when I pulled out the catheter, I was actually out of the arterial side through one of the side ports. So not perfect. I guess, I mean, if it's available, if you do that on the fluoro, that would like avoid those kind of caveats. But that's to the cost and all the burden of like doing that and time and things like that. Where like we usually do that pretty routinely. Like when we're not happy with the catheter, say, well, next time the dogs come in, the first thing we do, we just like switch over the wire and go into the treatment right away. And it doesn't add too much time to the treatment.
Are you guys, you bring up the fluoro, which, you know, that would let you see you weren't coming out of the side port for sure. I know there's a little bit of a mixed bag in terms of people's approaches for placing catheters using fluoro versus not. At NC State U, are you guys using fluoro for your catheters?
I use only if we have issues with catheter placement, especially in the cats. You know, I usually kind of go in the just regular OR. It's just because I'm used to using that room and I can keep everything so very clean in that room. So that's kind of my first goal. And then having the issues, and then we have to move into the fluoro. It doesn't happen often. Jim is more, you know, the oftentimes, especially in cats, you know, he prefer kind of start it in fluoro room. So there's a little bit kind of variabilities, but yes, we do use that fluoro. And then when replacing it, if there's any concern, yes, we do have the replacement in the fluoro room.
Yeah, I know Cedric and I have talked about this before too, you know, because there's I don't know, was it maybe 50-50? You guys might be able to comment more, like that are really dedicated and motivated to using fluoro for placement. I think up at Tufts, you know, I think JD is a lot of fluoro placement. I've not, I guess, expanded my skill set and all the other like hoops that I have to jump through to get fluoro as part of that placement. I've had decent results radiographing after the fact, unless, you know, a replacement would make good sense to feed it that way under fluoro. But
I mean, and that might be an unpopular opinion, but I really think that people should learn how to place catheter without fluoro.
Yeah, I would.
Because what if you don't have access to? I mean, you need to know how to do that without fluoro and keep the fluoro for complicated cases. If you have a portable fluoro that you can run in your room, I mean, good for you. But what if something's not working?
I think with experience, I mean, we've only used fluoro probably if we had to redo a difficult catheter, maybe one that was up in the azygous vein or something like that, to back it out. But I think with experience, you get pretty adept at knowing just by the feel and the flow and the way the catheter goes in, you get pretty adept at knowing where that catheter is.
Also,
then, you know, you obviously radiograph it afterwards to find out if you put it in the right spot.
Also remember the case of a cat that we were dialyzing, and I mean, for some reason they were doing some, I don't remember why, but we realized that the tip of the catheter, after a while, that was an ass cat. So the catheter was in the cold cava, or at least we thought it was, just right at the beginning of the cold cava. And I think they took x-rays for some other reason at some point, and the catheter was actually down in the ventricle. And so we were like discussing about kind of like pulling it back and trying to feed it like a little bit further in the cava again. But we couldn't have access to the fluoro. So what we did actually is like we pretty similarly, we fed the wire down, pulled the catheter, but then we backed up the wire and fed it into the cava just with the digital radiography. Because the fluoro was not available. So you're just like, okay, well, I'm going to pull back. I'm going to go back, take an x-ray. We're in the cava. Good. Let's fit the catheter on top. I mean, it's low tech, but it works. Like if you don't have fluoro and you still want to have some information, I mean, it's pretty easy now with digital radiography. You just push the pedal and you've got the image right away.
Yeah. I agree. I think I used that fluoro for just a few times. The time I use it as a cat, and I got the introducer and trying to send the guide wire, and then does not go to the place that I want to send, or I got the guide wire, but somehow I cannot push that the dilators in, and then just kind of have a little bit question, am I really in at the vein or on the outside? And I started questioning myself. That is the time I use a fluoro to making sure that introducer or the catheter is actually within that the vein, and I can send the guide wire to the appropriate place. That's the only time I use. And I actually do a cut down if there's any problem to getting access to the vein. I do cut down.
Well, I think that's the
I'm
same
glad
thing.
you mentioned cut down, because I think that's also a skill that people that are doing a lot of dialysis ought to be familiar with and facile with, because sometimes for me, I can do a cut down faster than I can sit there and poke percutaneously for 25 minutes trying to get the needle in the vein. So that's really a useful skill that a lot of internist type of people really avoid, but I think it's one that's useful in extracorporeal setting.
I've also started doing a lot ultrasound guided. So I try to do it without, and if I can't get it quickly, or if I hit it once and then have a nice clot up proximally and I need to go more distally, I can usually find it
But
that way.
to me, I just feel like those are two different things, right? Like the ultrasound guided, the goal is to get access to the vessel with your initial catheter. The fluoro is not going to help you with that. The fluoro is only guiding your wire and the placement of the tip of the catheter. I know that Emmanuel at Tufts told us that, for example, they were getting access to the vessel, they would feed the wire down with the fluoro, and then they would actually measure what catheter length they want to use based on that. Which is like an extra step. Like, I mean, you can, usually I try to guess from the anatomy of the dog and do some measurements with like the 6th, 7th rib. And I would say that most of the time I'm in the ballpark, but sometimes, yeah, I fall short or my catheter is too long and I'm kind of surprised. So I can see the appeal in that. My thing is just, I think you should be able to place a catheter without those additional techniques. And then that's just the cherry on top, or for complicated cases. What you're saying, you though, is I've had a case like that where we went to fluoro because we could not get a catheter in that cat. So we actually went to fluoro, and what I realized is like I had a good vascular access. I would feed my wire down, but what would happen, I think we were using a 7 or 8 French Myla, is that the wire would actually do the U shape again as soon as it was exiting my peripheral. And then it was too big for the vessel and was just like pressing on the vessel and would not advance. And so, and we could only see that because we were under fluoro, because the day before we tried to place a catheter and we couldn't, each time we could not advance the wire, right? And so we ended up actually pulling out a weasel wire that surgery uses for stent placement, a J-tip weasel wire. And that went like so smoothly that now if I need to place a catheter in a cat, I'm not going to use the wire from the kit anymore. And I think you can order those, and they have some really nice ones that are like 50 centimeters. Because I don't want to be dealing with the 150 that you're like flinging around and you don't know what to do. They have a 50 centimeter. I think you can order them from Myla. They're not that expensive. I mean, and it's making your life so much easier for those like cat catheters. So that's actually like, now it's my go-to. Like I'm not even like looking at the kit wire anymore in these cases.
Yeah, that totally makes sense. Yeah, sometimes this guide wire is just on J piece and maybe too big, maybe too stiff. Yeah, it just sometimes doesn't work on cats. So that's good to know. I'm trying to get this weasel wire. I thought the weasel wire is very expensive, but like you said, maybe from the Myla one is cheaper.
Yeah, I think the long ones, if you order them from like companies like Infinity and so on, they're probably about 200, 230 bucks each, which is quite steep. I think the one we got, I'm gonna say maybe something wrong, but I think they were like 50 to 60 bucks. But anyway, even without talking about the price, I mean, I could just imagine that metallic wire, guide wire, like scraping the sides of my jugular vein. It made me cringe.
Yeah.
So now I'm gonna go with a weasel.
Hey, Drew, when you're using ultrasound guidance, well, my technician Patricia's on here as well. So she's watched me flounder trying to use the ultrasound and spread the tissue to get the right tension on it, and then to try and feed in. How are you doing that? Do you have an extra set of hands in there? What's your kind of team approach when you're doing the ultrasound guided?
Yeah, I usually recruit a friend. And so somebody drives the linear probe and I try to place, right in front of it so that I maintain sterility, but still have access to see it. And I kind of do it like I'm usually at the head of the table and I usually have the ultrasound off to my left. I'm right-handed. And then the person that's driving it actually stands behind the ultrasound, so they can't really see what they're doing, but I line it up with the linear probe on M mode so that there's a notch or a marker in the middle of our probe that corresponds to the M mode vertical line on the screen. And so I have a better sense then of where I am and can give them a little bit easier direction as far as like how much to move. But it's it's a little different every time. I like Cedric said, I try to place them just percutaneously without anything, but I've definitely needed to rely on the ultrasound on a few of them.
Am I doing a deposit or anything for Billy?
Well, I think it's like whether you talk about the serial, DR images or fluoro or cut downs, to Dr. Calgill's point, or ultrasound guidance. I mean, these are all different tools we got to have in our kits because, however many percent go well, smoothly, just kind of straightforward. But it's always having that plan B, C, and hopefully not D, but it's there if you need it.
And I don't know if any of you have tried those handheld ultrasound for vascular access. Now they do one that is actually giving you both planes at the same time. So you see your longitudinal and your transverse at the same time. So you really can drive your needle pretty neatly. I don't know if it's the Butterfly IQ one or another one like that. But I saw that on a conference. I was like, ooh, I would like to try that one for my dialysis catheters because that seems like awesome. So yeah, I don't know if anybody jumped the gun on those and got one, but that would be interesting to get some feedback.
Yeah, we got one at Davis, and I regularly attend these apheresis conferences, and they usually have a lab at each of those conferences to talk about percutaneous catheter placement. And they used to have the great big, the ultrasound device that's kind of dedicated for that interventional stuff. But now all these labs are demonstrating these little butterfly handheld units, and they're really quite good. And they're not horribly expensive.
But the only problem I have with those is most of the one that I've seen, the head of the probe is quite big. And I feel like in a small dog and a cat, which likely is going to be when you have some trouble, once you put the probe on the neck, you actually don't have any real estate to put your needle. Or if you want to be like not like all the way up in the jaw, but if you want to be mid-neck, then your ultrasound is like on the ribs. So, I mean, as seducing as they may look, I would like to see how they perform in real life because I'm not fully convinced because of the size of the device. But I guess with miniaturization, we're going to see some better ones anytime soon.
Yeah, and the other thing that what we've done with it, you can they have a tiny little screen, obviously, but you can transfer that screen to an iPad or some bigger imaging device, and so we set that up, and I've hooked it up to a regular monitor, and then you've got a nice big view of what's going on. So I think that's a technology that will be really useful. I would probably agree with you that the size, I mean, obviously those things are designed for humans, and certainly for a dog, they may not be a problem, but cats may be a little bit of a problem.
Especially if you're trying to go longitudinally. Like I think if you try to go transverse, a smaller dog, you may still be able to get it there, but trying to go longitudinally, you often hit either the rib or the jaw.
I'm going to have to check out of the meeting in just a minute, but before I leave, I wanted to say a huge thank you for everybody who's participated in RRR. I was trying to remember how long we've been doing RRR. I think it's at least 15 or 20 years. I can't remember exactly when we started, but it was minimally 15 years ago, maybe as long as 20 years ago. And to my mind, it's been a useful and fun and a good way to keep community here. I think that was one of the big reasons that we started RRR years and years ago, was to just generate an extracorporeal community. And sadly, I'm leaving RRR as the host here, and very grateful and thankful to Jethro, who now is going to pick up the reins and persist with RRR and do with it as he wants to do with it. So Jethro, thank you so much for keeping the light shining here. And I'm going to try to come as often as I can come, but certainly it's in your capable, good hands going forward.
Well, I think just on behalf of the group who's here and not here, I mean, that community that you're talking about, we're going to work hard to continue that. But that's a testament to all the work that you and everybody that you trained and came, along with and after you built up. And we wouldn't be doing what we're doing without those efforts and that dedication and that mindset towards helping all of us do better. So definitely, we hope to see you a lot in these sessions to continue to pass on all that experience, because those are awfully big shoes for all of us to try and fill. So thank you for that transition introduction, though, and yeah, we'll see you as often as you can come.
You guys are just going to make it bigger and better. So go forth.
Dr. Calgill, along that same lines, would you mind sharing your email list for IRR with me, so I can continue to invite the folks that you had originally invited? And you're muted now, but you're still muted.
Oh, he was serious about backing out of meetings.
I guess so.
I was going to just make an announcement to that group, that I was leaving, but I'll forward it to you. I mean, there are over 200 names on that list, but I think there's probably 10 people that are still active, but you're welcome to the list. And then I think what we really ought to do at some point, I was meaning to do it over and over again, is to send out some kind of unsubscribe to this list or something, so that we get it down to the people that would really be interested in it going forward. But I'll send it to you.
Okay. Yeah, I can definitely do that. Thank you.
And just to call out, you guys might already be doing this, but just, as we've added new residents and that kind of stuff, I think because of our connections through Dialysis Academy, we were able to get these links, and then we fell off one email list and showed up on another one. So if there is like a dedicated website or a clickable icon or something where people can come and find this community, I think there's a lot of people that want to join. You just have to know someone to get on here sometimes. And so I think there may be more participation that's just getting missed out on, just because it's a little bit hard to get the right link at the right time.
It is on, there is a dedicated page on the acvnu.org website that has the information on how to join, because the link is the same for every session, or at least I try to make it, and I try to update it. And then I also post on ACVNU social media, or try to at least to get it out there from a broader perspective. But you guys are welcome to always email me as well, if you want. And that's, you can do that through the info@acvnu.org or summer.coda@acvnu.org. And I'll definitely add you to my permanent list anyway.
Awesome. I'll let people know. That's very helpful.
Okay. Bye, Dr. Calgill.
Thanks, Dr. Calgill. Well, and Jay, to that point, I mean, there's, Summer and I have been talking about some of these historic lists, but your point, the invitation to a broader audience, through our ACVEC listserv, through the ACVN listserv, the ACVNU, like all that is out there, but a reminder to pull in some folks that, like you said, might not be being captured by some of these distribution lists. Kind of getting a refresh on that community going forward, as well as all the historic names that we sent out to. So I think as Cedric and I have been talking about, how to build this into an interactive and exciting kind of place to come and commune and share cases and continue with all of the groundwork that's been done here. that may be a nice way for us to then build up with some of those new faces that maybe weren't part of the academy, didn't know, but are still doing, a lot of good work in extracorporeal therapies. And maybe we can bring in some of those folks to make sure we're all on the same page for some of these things.
Yeah,
Yeah.
I'm also happy to like put together like an announcement, Jethro.
Yeah.
And if you guys that are on or have access to the ACVEC listserv, wanted to share that there, I could include the link to the sessions, and we also record all of these and they're on our YouTube page if they want to watch them afterwards as well. So I'm happy to do that, and so you guys can spread the word that way too. Or if you have any other ideas, please let me know. I'm happy to help, because I think I don't know. I think it's an interesting session that you guys host, and I don't even know what you're talking about. So.
I didn't realize they were going up on YouTube. I guess I better be careful what I say.
Oh yeah,
about
yeah,
that.
no,
Yeah.
they're
I
all
know
up
that
on
one a
YouTube.
couple weeks ago. It's like a total M&M on how many times I messed up in about an hour and a half, and now it's out there for the world.
Yeah, maybe we should put that behind a password wall or something, right? I don't know. I may not
You
use
guys
my.
are just gonna have to behave yourselves.
I'm not sure we're able to do that. We'll have to shut down cameras probably too.
Well, if for those of you guys, I think a handful. I'm not sure. Erica was there last week, or last session when we were treating a little AKI dog on our Blue Star platform, and really struggling with pressure alarms and TMP and sensors. And one of my helpers in there, Alicia, was just pushing the mute button every 2 minutes so that we could actually talk over the alarms. But it was, listen, none of us are perfect. Well, I don't know. I won't speak for all of you guys, but I found it really helpful. Eric and I talking through some of the challenges I was having, in real time, and I think a few of the other folks on the call as well. So I think it's good to put some of that stuff out there, like we've always talked about. Like, let's talk about what goes wrong, not just all the amazing things that we're doing. Hopefully,
And I
that
really
does.
think, yeah, I really think that's the value of international renal rounds, because I think we all face some struggles with some part of the extracorporeal at some point. And the fact we can bring it up in front of an audience and everybody's going to have some tips and tricks that we didn't think about. I mean, all these little details that, I mean, I've been lucky enough to be trained by Dr. Cargill and Dr. Ross. So a lot of these little tricks I actually learned during my fellowship. But a lot of people do not have that extensive training with such great mentors. And so I think it's a great way to like get all these little tips and tricks from like a lot of different, and also get some different perspective. I think it's very interesting because we don't do the same in San Diego or Davis or Tufts or North Carolina or Cornell. And I think again, just like going back to the vascular access placement, the more tools you have in your toolbox, the better you will be able to face unexpected situations. And that's the point. And you don't want to be able to place catheter only one way, but multiple ways, because the one way is going to work 9 out of 10, but that's the 10% that's going to make the difference between somebody doing dialysis and somebody really good at dialysis, right?
I think the other valuable thing that I just want to shout out for a lot of the people that are on here is this is still very much an oral tradition procedure for us in vet med. Like, none of this is written down, or it's written down in very disparate sources that are hard to get to. And I know there's a great group working towards that, but I think for Drew and I's learning, yes, we attended Dialysis Academy, and we're in private practice, but we didn't do fellowships. And so just trying to find the information, like we come to these sessions, we hoard this information, we write it down, we try to capture it in a way that we can share it with others and residents. But, as someone who really likes to do evidence-based medicine and try to figure out best practice, it's really oral right now. It's all just word of mouth. And so I think having these sessions until we get more of it written down, and then also, as we know, the second you write it down, it becomes obsolete because there's progress as well. So I think for both of those, this is invaluable.
Well, I think I think it's the 2014 edition, something like that, with Advanced Renal Therapies Symposium, that the dialysis handbook, which is a little bit outdated now, but I mean, that's something that I've referred back to so many times. To your point, Jay, just having something as a reference guide. And that's, something definitely 10 years later or more, it's time to maybe update that. And
And I think like the good thing for late 2025, early 2026 is that after the IRRS guidelines for AKI and IHD, we're gonna have the IRRS guidelines for CRT, the IRRS guidelines for hemoperfusion. I know that some groups are gonna also take over apheresis or vascular access. So we'll probably have at least a set of guidelines, if not evidence-based medicine, but at least a set of guidelines that will capture some of that oral tradition in the next year or so.
Yeah, I mean, I think like Jay was saying, and even you alluded to, Cedric, not all of us were trained in places with amazing colleagues that we could ask questions to. Like when something goes wrong for me, I'm calling a rep or I'm calling somebody on this call, because if Jay doesn't know, or he's not in the building, which is more and more these days, then it's me, and I got to figure it out. My residents are there going, oh, what do we do now, and how do I help with this? And I don't have that support of that previous community. So this is my community to learn how to do dialysis and to bring extracorporeal therapies to my practice. And at this point, I'm very happy for Kathy Langston, but I am now the only practitioner doing extracorporeal therapy in Ohio, and my caseload has gone up considerably in the last few weeks, which is a good problem to have. But you know, I really value this group as a place to bounce off ideas and to learn and grow every other week, because honestly, there really isn't another community like this in other disciplines. You know, like you're learning how to use the ventilator, like there's no group that meets every other week to tell you how to troubleshoot that. And there's plenty of things to troubleshoot there. So I think this is really unique and really special. I find it very valuable.
Well,
Yeah, and I think we'll do our best to keep it going. I'm gonna need to actually leave the meeting because I've got a procedure in the OR I need to go to. But that was a real pleasure to see all of you, and I'll see you back in 2 weeks. That's
right. Cedric will be taking the reins on the 5th. I'll be on a flight. I might try and log in from the flight if I can, just to, there'll be at least a blank screen in the background somewhere.
Yeah, I'll take all the support I can.
All right. Awesome. Well, Drew, I mean, to your point though, one of my biggest, I think, concerns around these sessions, which is why I'm so glad to see so many different names up here. I'd love to see some faces too. I'm all about the cameras too. Is that it has to have all of us here to be as powerful as it is, to share those experiences. Before you guys logged on, it was, you know, I think it was Cedric, Jeff, me, and Calgill maybe for a minute there. And then you signed on, Dr. Ueda, and then you guys at MedVet. So it grew, which always takes the pressure off. I'm like, oh, great. There's more voices, there's more stories. So from that perspective, you know, as we build hopefully this core, and not everybody's gonna be able to make it every session. One of the things I think it's important for us to look at maybe the timing of this session as well. It's pretty, I think, North America centric. In the timing, we got a few emails last night, you know, on Friday evenings in Israel, for example. You know, it's family time, they're already having dinner. Some of the folks in other you know, kind of European time zones and around the world, it's not the ideal time for this meeting to happen. So, or, you know, JD on Fridays is in appointments. So even though it's a North America kind of centric 11 a.m. Eastern, 8 West, it's not ideal for some of our working days. So that might be something that, you know, as we go forward, we look at finding that optimal time, or we have to accept, as with everything, we can't make everybody happy. But I really want to maximize all you guys being here so that we've got a lot to talk about.
I think the link access will help a lot too. I mean, Drew was late today because whatever link he had expired or wasn't working, and I had a more updated one because I was, you know, still getting updates from Dialysis Academy. So I think that attendance is a little bit impacted by that too.
All right, great. Yeah, well, I know Summer's working hard in the background, so we'll
unfortunately for a long time, I guess at least for the last year, the only updated links have been sent to Hemodialysis Academy participants, because Calgill has forgotten sort of to send stuff out. No judgment, but like, yes. Yeah, so I think that if we could get a more updated list, that would be great.
Hey,
to at
Jay,
least send the invites out, and then and you guys, like I said, are welcome to share as well.
Jay
Go
and
ahead.
Andrew, what platforms do you have? I'm out in Colorado, so you guys are 2 hours ahead of me. And if you're needing some help in, troubleshooting and things like that, I'm happy to, be that support if you need. What platforms do you have? I think you have the Amicus from what I recall, and then I'm not quite sure from the dialysis side of things.
We're not into dialysis yet. We've got the Purify pump and are doing hemoperfusion.
Okay.
Yeah, I was gonna say Drew can speak to this, but most of our caseload is hemoperfusion related because there's just so many toxicities that obviously have to be managed around the clock.
Right.
Hopefully, in the next 2 to 5 years, as our critical care service grows, we'll get into that part B, and we will definitely take you up on that portion of it because obviously that's a little bit with the prescriptions and some of the more ongoing care that is a little bit more involved. But yes, I appreciate the offer as well. I mean, because we do get a lot of great information from our reps. Like, shout out to Fresenius and Amanda Jeffries and that group for supporting us on the Amicus platform, and for Parker for supporting us on the hemoperfusion, and Jeff Barnes and his group with Analogic. But some of it really is this like coagulation complication, catheter complication stuff that the reps are sort of like, oh, that's your jam. I'm like, yep, now I hear you.
Stay in our lane.
Yeah.
Well, I think the other, to Dan's point, and I know we've said this before, a number of folks have said like this community isn't just about every other Friday as well. Like we've got the ability to have these sessions kind of ad hoc as well. In the middle of some of those treatments that are happening, we can have a session and really kind of troubleshoot together as well. So there's lots of other opportunity in the heat of the moment or in between these every other Fridays where we can get together and chat and hopefully learn and then bring some of those off week discussions back to the big group as well. So, well, that is it. 12:01. This has been a great variety of different topics here. A lot of around. I know Cedric's case with the we did a little bit of talking about nephropilocentesis. Talking about recurrent AKI in his patient, the catheter exchange. We got into, placements, fluoro versus, repeated DR images versus bifield and eyeballing and measurements, and then radiographing after the fact, cut downs, ultrasound guidance. A lot of great stuff came out here. So, and then, yeah, I'm hopeful Dr. Calgill will still come in as often as possible. We had a really nice exchange last night where he said, "Hey, I'm still going to be there as much as possible, but please do grow it as we all see fit." I think this is an organic group, and I'm excited to see where we all take it together because that's where the power is. It's all of us working together on this. So with that, Dan, you turned on your camera. Do you want to do the famous last word here before we end the session?
Just keep spinning.
Love it. It's good to see you, man.
Good to see you guys. I'm curious on your Blue Star stuff. What kind of I'll have to go back and listen to that. I was not free the last session, so this time is a little bit tough for me. I'm like JD. I'm kind of I'm in and out of appointments, so it does get to be a little bit challenging to jump on. But yeah, curious how you like your Blue Star.
So the issue we were having the last session was using the smaller sets. So I was using was it a 2.4 millimeter set, which just led to, because they've got different hookups in there, and the pressure port on the arterial side isn't present, and I was fiddling with my venous side as well. So we were just fighting through some of those access issues that the machine doesn't pick up on. So we were talking how I was watching for error in the line, and Erica was sharing some of her experiences with that, and then the TMP alarms on the other side because I didn't always have my venous pressure pod in the right spot. So with the large circuits, it's been great. I've loved every bit of it. It's got its own personality, of course, But it was as we transitioned, we had a smaller patient, and our ability to use the Prismax on this dog, we didn't have the right stuff for it. So we switched over somewhat without as much prep as I would have liked. So we're just troubleshooting through some of those circuit alarms and issues and challenges.
Gotcha.
So
What was your blood speed on that patient? Because we definitely had some troubles most recently on that. We got a dog actually right now that's going on that circuit too, and it's really kind of frustrating because you have to look at your arterial side the whole time.
Yeah. No, that was it. We were running at, I think that dog was at 50 mils a minute.
Okay.
She was just under 10 kgs, I think.
Okay.
And there is, we started talking about this, there's the priming port there on the arterial side. And I hadn't done it yet. I don't know if Erica wants to jump on and talk about how she's kind of jerry-rigged an extension set with a little pressure pod on there, one of those little filters, and then attach that to the arterial access side and gotten some pressure that way. So you didn't have to like eyeball looking for it to be like, drying
Gotcha.
up on you.
Yeah. Right.
But
Yeah.
I've got to run some sims, on some fake patients here.
Gotcha. Yeah, I think when we've maxed out our blood speed, like an 80 mil per minute, we've definitely seen a lot of pressure alarms, and even blood backing up into the heparin syringe.
Yep.
So we've had to run the heparin separately as a result of that. But we've had some really obscure cases recently where a dog that should have tolerated a larger circuit was not, and so utilizing these smaller circuits where I need a faster blood speed, or else I'm treating for a longer period of time to get the adequate clearance that I'm looking for. It does get to be a little bit challenging, especially when you're trying to max out the blood speed as much as you can. So that's been if I get a patient that's like over 7 kilos, then it tends to get to be a little bit more trouble than it's worth sometimes.
Yeah, we had, we did about 30 treatments in a 30 kg or so lab with ongoing treatment for her AKI that then became chronic. And the Blue Star with that, and then that was with the 8 mm set. It worked really smoothly. We got great blood flows. It was just as we moved down into the smaller circuits that we're learning the hard way.
Did you because I've had some colleagues talk about when they calibrate the machine initially, what circuit that they're calibrating with. So I had the Fresenius rep calibrate on our pediatric circuit first, because initially when they came out and calibrated, they did it on a traditional adult circuit, and then I had them come back out and calibrate on a smaller circuit size, which I found that we had less pressure alarms as a result of that, but I don't know if that's just correlation or causation, honestly.
We had that discussion with our trainer and our rep, and then Carolyn Ty up at Tufts had kind of suggested the same thing. They are primarily using it, I think, in that mid range. I think the 6 or maybe even the 4 size tubing sets. When my understanding of the calibration was that it was more around the air chamber, the air detection chamber, and that was the major point where it was going to run into trouble if it wasn't calibrated per set. And I didn't have any alarms with that when I switched over to the smaller sets. I thought I was going to, but maybe my TMP issues, or at least my alarms, were partially a function of not having it calibrated to the smaller lines. But they ran, like when I wasn't getting catheter, because I think it was access issue more than anything with the catheter I had. When I wasn't getting that, which wouldn't have mattered what set I was using, the rest of it seemed to function okay once I got over the TMP alarm, and I made it happier by getting my venous side pressure pod attached there.
Okay.
Did we lose? Oh no, Erica's still there. Erica, do you have anything to add to that in terms of like calibration stuff?
I don't. I had heard that as well. I'm going to reach out to my tech to see what he says. I feel like they blow me off when I say it doesn't need to be recalibrated. I thought I had sent the Colorado group the like pressure transducer setup that we got from the Children's Hospital.
I saw that. Yep.
Yeah. So we've done it once. Like I do think it worked. Oh, I've done it twice. It does work to stop the pump. But if you get repeated access alarms, one on top of each other, you can still get the scenario where my pump isn't stopping for some reason and then pulls a bunch of air into the circuit. So we're not entirely happy with the Blue Star and those little circuits compared to the Phoenix. Obviously, we agree with you that the bigger circuit with the arterial and venous chamber, it works great and we're happy. It's just the small circuits that we're just not over the learning curve yet either.
Yeah, I think the catheter does play a really big role here. And, like this dog that we're currently treating, on the carpe diem, for example, we're just getting a bunch of alarms. And I think that's going to be the sensitivity of that machine versus, the difference in sensitivity to the IHD machine. And, I do think catheters in the smaller patients like cats and small dogs, I see that more and more commonly. And when I flip them over to the IHD circuit, I get less pressure variations, and I think less pressure alarms as well. And so, I think we have a catheter issue in our small patients. There's just not the perfect catheter out there from a length and diameter per se. I wish that there was like a 6 French 13 centimeter. Jeff, you listening? We need a catheter.
And made of silicone, not polyurethane.
There it is.
I will say
On my
that
list.
I was going to say about the catheter lengths, it's something I haven't tried, but when I have discussed things with the Children's Hospital, they have very much the same issues that we have, and they often will cut the catheters. So their IR team will put them in, and then to get them in the right position, they cut the tip, and which frustrates the nurses because then the nurses don't know how much to lock the catheter with.
Mm-hmm.
But it is somewhat routine, I should say, in babies.
That's good to hear.
Let me know if you try it. I haven't done it
That's
yet.
terrifying to hear.
I'm down to try it.
Maybe I shouldn't have said that out loud, but yeah, they do that.
Here we go. Here's the sharing of ideas that we're all talking about. Cutting catheter.
I mean, because most of the time you're dealing with like a 16 centimeter catheter, or you're dealing with an 8 centimeter catheter. The 13 is, the diameter is too small and it's too long, so you get resistance issues. And there's just so many variables that play a role here that if we could, find the standard cat catheter that isn't too much of a nuisance. It's hard to get the blood speeds up on that carpe diem when I'm treating a cat, because a lot of times I'm just dealing with pressure related issues just from a catheter, just the catheter characteristics, I think.
Catheters.
I'm gonna have to jump off, but good chatting with you all. And Jethro and Cedric, thanks for taking this over and adding it to your plate.
Yeah, well, hope to see you as much as we can.
Will do. All right, guys, take care.
All right, with that, I think I'm going to draw this to a close, and thank you guys for being ongoing parts of the community. Drew, I wondered if you guys had cases to talk about. Usually we get you on here when there's something going on, and maybe at the next session we'll hear about some of the trials, tribulations, and successes that you guys are having too.
Absolutely. Love to.
All right. Well, thanks everybody. Have a great day. Thanks, Summer, for organizing us.
No problem.
Thank you.
Bye, guys.